everyone. We apologize for that hiccup, and we welcome everyone to today's webinar. I'm Leah Fishbein with Becker's Healthcare. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. We are pleased to have Scott Becker, publisher of Becker's Healthcare, here to moderate today's question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Answer a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we'll be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Kylie Kaiser is responsible for overseeing all clinical and regulatory affairs to National Medical, the largest ASC revenue cycle company in the country. In her previous role, Kylie served as executive director of a multi-ambulatory surgery center organization and has used her unique clinical and operational background to drive quality in patient care and organizational growth and development. As Vice President of Clinical and Regulatory Affairs at National Medical, her distinctive experience in healthcare service and business operations allows Kylie to provide National Medical and their clients with supportive collaboration and guidance as they navigate throughout the ever-changing healthcare environment. Kylie, I'll now turn the floor over to you to begin today's presentation.
Thank you so much, Leah, for that kind introduction, and good afternoon, everyone. It really is my pleasure to be with you today to speak about regulatory affairs and the revenue cycle in the ASC industry. I feel that this presentation is aptly timed. Just a funny story to share. Earlier this week, I had the opportunity to visit the Washington, D.C. area, and I very quickly got a firsthand look at what regulations surrounding picture taking on federal property looked like. It is frowned upon, just so everyone knows. We could have had a worse outcome, so I'm just happy to be back here and be presenting for you all today. But in all seriousness, while I recognize that politics and really anything related to politics is perhaps not everyone's favorite thing, today more than ever, it is increasingly important for healthcare providers to pay close attention to regulatory affairs. With potential impactful changes to both federal and state regulations, you really have to keep your finger on the pulse of our industry. My goal today is to share with you the current state of healthcare reform, the impact on our industry, and what you need to be on the lookout for. So as such, today I will focus on healthcare reform and the trends and networks that we're seeing as a result of growing healthcare costs. Additionally, we will explore the CMS 2018 Hospital Outpatient Prospective Payment System and Ambulatory Surgery Center Payment System proposed rule, and what this means for procedures in the ASC setting and CMS quality measures. And finally, we'll dive into a key piece of legislation that is ASC specific, and we'll talk about how advocacy efforts impact lawmaking. And of course, along the way, we'll identify just how all of this can impact your revenue cycle. Let's begin with the federal overview. And in a nonpartisan way, we really have to explore what's actively happening with healthcare reform in our country. The Affordable Care Act and Reconciliation Act was signed into law in 2010 under the Obama administration. And at that time, there was great support and great opposition to this legislation, not unlike the support and opposition that we're seeing today with repeal efforts. ACA repeal and replace efforts have been a primary focus of the current administration, and these efforts have gone through numerous proposals and revisions, as you can see here. We've had the American Health Care Act, Better Reconciliation Act, Healthcare Freedom Act, and it goes on. And as of just a few weeks ago, all repeal or replace efforts to date have been unsuccessful. We'll take a look at the most recent proposal, the Graham-Cassidy bill, to develop an understanding of the direction of potential reform and review considerations should the legislation stay in place or should reform pass. The Graham-Cassidy bill, appropriately named, was healthcare reform legislation brought to Congress by Republican Senators Lindsey Graham of South Carolina and Bill Cassidy of Louisiana. The Graham-Cassidy bill was scheduled for Senate vote prior to September 30th, when Republicans would be able to pass healthcare legislation with only 50 votes under budget reconciliation rules. And of course, they would utilize Vice President Pence as the tie-breaking vote. This proposed bill would convert the Affordable Care Act into a block grant program, and that would put more power back to the states, allowing state lawmakers to create their own health policies and have independent discretion on consumer protections. ACA subsidies totaling $1.2 trillion would be parceled out to the states through 2026, and Medicaid expansion would be set to end in the year 2020. Republican Senators John McCain of Arizona, Rand Paul of Kentucky, and Susan Collins of Maine had been consistently vocal in their opposition to presented reform, including the Graham-Cassidy bill, with their biggest focus being on the cuts proposed to Medicaid and state control on consumer protections, with pre-existing conditions really being the driver there. The impact on annual federal funding levels by the year 2020 under this bill does vary dramatically state by state, with Mississippi seeing the highest funding increase with a 340% increase in funding, Iowa remaining neutral, and Maryland losing 51% of its federal funding, with the remaining states falling somewhere along that spectrum. As a result, not having enough support approaching a vote, even after this bill increased Medicaid funding for key states, the vote was canceled in September of this year. But understanding that healthcare reform was a very major, if not the most important platform that President Trump and many Republicans ran their campaigns on, we recognize that the efforts will not stop here. Since the vote on the Graham-Cassidy bill was canceled, President Trump has announced that he hopes to work with Democrats on a bipartisan reform in early 2018. And even here recently, he's begun reaching out to Democratic leaders to begin negotiations. Senate Minority Leader Chuck Schumer, that you can see here, he was quoted recently as saying, "If the president wants to work together to improve the existing healthcare system, we Democrats are open to this suggestion. A good place to start might be the Alexander-Murray negotiations that would stabilize the system and lower costs." Senator Schumer did not suggest that Democrats were open to repeal or replace efforts, but rather that they were open to improving the existing system. Senator Schumer's suggested starting place was reference to the bipartisan healthcare proposal by Senators Lamar Alexander, a Republican of Tennessee, and Patty Murray, a Democrat of Washington. Now, the plan here was to craft a short-term bill that could stabilize the individual healthcare markets, which we all know has been one of the most volatile aspects of the Affordable Care Act. This proposal includes making sure that governments issue out key payments that help offset insurers' costs of covering certain Americans' healthcare needs. Cost-sharing reductions are paid to insurance companies to help offset the cost of discount health plans that they provide to Americans, making up to the 200% of federal poverty limit. As you can see here, the breakdown of the different states, we see that they individually rely on the cost-sharing reduction funding. 13 states are in the 60 to 78% range, with several not far behind that, and really all states were set to see some type of impact from this change. President Trump did sign an executive order late last week promoting healthcare choice and competition. This order immediately stopped the funding of the cost-sharing reductions, citing that the Obama administration had circumvented the appropriations process and was unlawfully using unappropriated money to fund reimbursements due to insurers through these reductions. After a thorough legal review by HHS, the Treasury, Office of Management and Budget, and an opinion from the Attorney General, it was believed that the last administration overstepped the legal boundaries drawn by the Constitution here. They identified that Congress had not appropriated money for cost-sharing reduction funding, and as a result, the payments were immediately discontinued upon the signing of the executive order. However, as we often see in politics, things change very quickly. So as of just a few days ago, Senators Alexander and Murray announced the outline of a bipartisan agreement that would stabilize the individual insurance markets by extending these cost-sharing subsidy payments to insurers through 2019. That would projected to be a total of $7 billion this year and $10 billion next year. And the hope here is that this will aid in the market's transition away from cost-sharing reduction subsidies in total. The executive order was also aimed at expanding insurance options for Americans who buy coverage on their own or for those who work for a smaller employer. The executive order directs the Department of Health and Human Services, the Treasury, and the Department of Labor to take action to increase competition, increase choice, and increase access to the lower-priced, high-quality healthcare options. This order also works to limit excessive consolidation in the healthcare system, and as we know, consolidation has been a concern for ASCs as of late. Low reimbursement, technology costs, and heightened regulation have led to an increase in mergers and acquisitions in our market as a result. One thing is absolutely certain: we will most definitely continue to see more on potential reform with the turn of the year, and we'll most likely watch bipartisan efforts to improve healthcare here. So how does all of this impact the revenue cycle? Now, the majority focus of the current legislation and even potential reform efforts is centered around Medicaid funding, with more than 20% of Americans currently on that program. Now, although we understand that Medicaid in itself does not have a necessarily direct impact on the ASC industry, there are significant impacts of healthcare reform to the revenue cycle, regardless of the direction or the route that reform might take. So what's the impact if legislation stays in place? Well, under the Affordable Care Act, we've seen a dramatic increase in premiums, deductibles, and this heightened cost to both consumers and employers. We could expect that these trends and the challenges associated to those would also continue. And what happens if the proposed reform passes? Well, the reform could create limited coverage or loss of coverage for some individuals, which could then turn to lower patient volume for providers, or even higher costs associated to a higher uninsured rate. In today's environment, you absolutely have to view the patient as a payer. We've seen this 83% increase in employee contributions over the last decade. 83%, that is absolutely significant in our market. According to the American Medical Association, patient responsibility now makes up 25% of total revenue, with experts anticipating this to reach 50% over the next decade. We've seen this increase in self-pay and self-funded patient volume that leads to significant bad debt for providers. And as you see here, 68% of patients report some type of financial difficulty in paying their medical bills. This only makes it harder for providers to collect payment for services and to get paid appropriately. From just 2015 to 2016 alone, the number of consumers failing to pay full patient responsibility increased by 15%, and we anticipate that number to continue to go up. As a result, we're seeing a growing focus on collecting patient responsibility and appropriately estimating time of service costs for patients. Facilities and practices are also exploring where their inefficiencies and their wastes lie, and they're aggressively working to cut costs while maintaining quality and care. I don't believe a single day has gone by here recently where we haven't seen some type of news brief about layoffs or staffing cuts in the healthcare industry. Rising costs are forcing organizations and practices to become as lean and efficient as possible. The healthcare arena is shifting to the utilization of automation wherever applicable to combat these inefficiencies, and we're seeing this trend with automation in revenue cycle as well. We're also watching managed care contracts become more and more complex, and we're now even seeing state legislation regarding price transparency catching on. So let's take a look at how managed care organizations and state legislation is battling rising healthcare costs. First up, narrow networks and bundled payments. Now, the hyper-focus and the need to control these rising healthcare costs has led to the rapid growth of narrow networks and bundled payments. With 30% of total U.S. healthcare spend being surgery-related costs, and with 82% of large employers, those with over 500 employees, choosing self-funded plans or plans where the employer is responsible for payment on a claim regardless of its affiliation with an ASO or an administrative services organization, the employers now have a very significant voice in our industry. We're actually suggesting that the industry adopt a new payer class that is labeled self-funded, so that we're able to properly track these plans and the employer groups for reporting purposes. In addition to mainstream employers, more than half of the states in our country self-fund their health plans for state employees. And nearly every state has at least one self-funded plan option for state employees. Therefore, this type of model is all throughout our market today. As a result, managed care organizations are tightening up their contract language. And if you aren't aware of these trends, you'll end up seeing a direct impact to your reimbursement rates and your revenue. And I'm going to spend some time on this slide really reviewing where these arrangements are changing and how this can impact your revenue cycle. Specialty product and payment responsibility language in managed care contracts today makes it extremely important for you to understand your patient population. Specialty product language gives the payer the right to exclude your participation in a specialty program, which could result in the loss of patient volume to their plan's preferred providers. It could also result in unpaid claims because your physicians are not credentialed into that narrow network. The managed care organizations are also including language that reserves their right to include your participation in their narrow networks. And now, while this can have a positive impact by driving volume to your facility, if you're not carefully negotiating your contracts and understanding this language, you could end up with a contracted rate in the narrow network that is actually lower than your standard rate with the managed care organization. With regard to payment responsibility, we are seeing language that states the managed care organization will pay on claims for fully funded patients. However, they have no legal responsibility to pay on claims for self-funded patients. So in this scenario, when a claim is not paid and your team is appealing to the carrier, but it's actually the employer who's responsible for payment, this will result in a waste of resources and time for your facility. And regardless of how many times you appeal, you will not succeed because you're appealing to the wrong group. So again, understanding your patient population will be critical to your navigating the changing managed care contract language that's resulting from rising healthcare costs. Managed care organizations are also including language restricting your ability to directly contract with employer groups, which, depending on your market, could actually be a very profitable arrangement for you. They're doing this because they're viewing you now as competition when you're directly contracting with an employer group, and they see this as a way of you taking away some of their revenue. So being sure to ask, who are your employer groups in your area? What do your contracts dictate about contracting with employer groups? These are going to be very important questions for you to ask when you're reviewing your contracts and your addendums today. Some high-performing narrow networks are also implementing additional credentialing requirements, and that's making it more burdensome to be included in these narrow networks. As we all know, credentialing is not necessarily a quick or an easy process, so you can see how this would be an additional tax on your resources at the facility as well. Generally speaking, there are significant changes in narrow networks and managed care contracting emerging from the rising healthcare costs and really the need for cost containment in our industry. So let's explore the other growing trend with managed care organizations, and that is bundled payments. Bundled payments are the other arm of our industry's response to rapidly growing healthcare costs. Bundled payments pull together all services associated to an episode of care, and they assign a cost to that entire episode, and we're watching this system expand into the ASC space now. At this point, almost all health plans or hospitals are using some combination of value-based and fee-for-service reimbursement models, with bundled payments being the most rapidly growing form, making up nearly 20% of all reimbursements over the next 5 years. Bundled payments really are not new. They've existed in the hospital setting for years. However, it's just that they're now applying to procedures performed in an outpatient setting in an effort to support cost containment. Bundled payments do benefit patients in that the patient ends up receiving only one bill for service instead of individual bills for pro, ASC, anesthesia, laboratory work, things like that. Sometimes patients are receiving these bills up to 2 years later after they've received services, and oftentimes the bills aren't even correct. So it truly does help the patient manage their expenses when it's all coming from one source. Managed care organizations are tackling cost containment with these high-cost procedures like your spine and orthopedic cases, and they're doing so through the use of bundled payment outsourcing companies. Now, with these arrangements, language in your contract specifies that all providers associated to that episode of care must be contracted with the outsourced bundled payment company in order for the bundle to work. And you will most likely have a separate rate for this agreement that may be lower than your contracted rate with the managed care organization. Now, while we all want to support controlling costs while at the same time remain truly committed to improving quality and care, it is going to be your absolute responsibility, the responsibility of the individual surgery centers, to really know and understand your contracts, your agreements, or your addendums to ensure that you're properly managing your patient population in an effort to support a positive impact to your reimbursement and your revenue stream in this environment where it's increasingly difficult to get paid for services. Also important to touch on under the federal update umbrella is the recent change in administration for the United States Department of Health and Human Services. Dr. Tom Price was named to Secretary of the Department of Health and Human Services under the current administration in February of 2017. However, on September 29, 2017, he did resign his position as Secretary for HHS following criticism of his use of private charters and military aircraft for travel. Now, political affiliations aside, this was really viewed as an unfortunate event for the ambulatory surgery center industry because Dr. Tom Price is an orthopedic surgeon, and he's also a previous ASC owner. And with many of the pending changes in the ASC industry coming up, he was really looked to as an advocate for ASC affairs. But nonetheless, we do continue on. Dr. Don Wright assumed the acting assistant secretary role immediately following Price's resignation. And just last week on October 10th, President Trump named Eric Hargan to acting secretary of the Department of Health and Human Services until a permanent replacement is made. Hargan was previously a lawyer in Chicago. He served at HHS in the Bush administration, holding various positions like Deputy General Counsel, Principal Associate Deputy Secretary, and Acting Deputy Secretary. He was also part of President Trump's HHS transition team, and he remains a potential replacement for Dr. Price, along with potential candidate FDA Commissioner Scott Gottlieb and CMS Administrator Seema Verma. Now, although no formal nominations have been made to date, these are names that continue to come up, so stay tuned for more on this matter. Here just recently, also on a national level, we've seen the launch of the National Quality Forum's Health Equity Program. Now, this program was designed to eliminate health disparities by addressing social risk factors that adversely affect excluded or marginalized groups. They hope to do this through the implementation of several programs and collaborative efforts of stakeholders, and they'll be analyzing quality efforts and their impact on health disparities. Now, I bring this to your attention because we already know that ASCs report on quality measures, and this type of program has a goal of utilizing performance measures to appropriately reward or penalize providers based on their ability to reduce disparities in their communities. They're doing this through partnerships with stakeholders. Most recently in 2017, they've received funding from the Aetna Foundation. So it's definitely something that we want to watch as this initiative continues to grow. I think it's very reasonable to believe that we'll continue to see more programs like this as well as our entire industry is really shifting toward quality-based models. And now let's move into state regulatory affairs. So I mentioned earlier that state legislators were getting involved with rising healthcare costs, and they're doing so by way of price transparency and balanced billing laws. At present, 25 states in total have some type of cost reporting, time of service estimation, or healthcare price data accessibility requirements in their legislation. Early on, this was popping up primarily along the West Coast, but today we're really seeing it across the country. The National Conference of State Legislature is a great resource to review the individual states and their applicable state actions related to transparency and the disclosure of health costs and provider payments in laws. I've included some examples that you can see here of trends that we're seeing in state legislation and regulation that will make it more difficult for providers to collect on patient balances. I actually had the opportunity recently to speak in several of these states on the exact topic of price transparency and balanced billing legislation, and I learned just how burdensome this change really is for facilities and for providers. In Oregon, for instance, the new state legislation will prevent providers from sending patients to collections in the event that the insurer will not pay on a claim where there are out-of-network providers. This ruling also tiered what reimbursement would look like for providers based on emergency care criteria. In California, surprise billing legislation includes a reimbursement rate for non-participating providers that is set at 125% of Medicare allowable. And this is a rate that we're seeing in many states under similar legislation, so that in itself is a direct hit to your revenue. In Ohio, the legislation takes a slightly different approach, and because of some significant opposition to this bill, the law has not yet been fully enacted. However, this legislation stipulated that the provider or the facility must provide a good faith estimate to patients regarding what services will cost them, and they must do so before beginning any treatment. Now, the major concern here is that the burdens associated with providing this information are additional costs and resources to the facility, but even more so, it's the potential for the delay of treatment for patients, which can lead to decreasing quality in care. Florida currently requires that licensed healthcare facilities provide itemized bills to patients upon request, and that non-state facilities must publicly post cost information for consumers. With looking at the patient as a payer, we all really understand that patients will increasingly become informed consumers who will begin shopping for the care that they want to receive. At this point, there are several sources where patients can compare surgery costs, like FairHealth, Healthcare Blue Book. However, there's really no adequate measure for quality when also looking at costs. And as you can imagine, basing your healthcare provider decision solely on cost could lead to poor outcomes and poor quality of care. Cheaper does not necessarily translate to better in healthcare, so we're going to have a major focus on quality going forward. So what is the impact of state legislation on the revenue cycle? Well, we could see loss of patient volume. Now, based on the state legislation examples that I just gave, the ASC has several opportunities to lose patient volume. Either you only see patients in particular networks, perhaps you can't handle the demands of estimation and therefore your volume drops, or you lose potential clients to a competitor who may be cheaper than you even though their quality is less. There are undoubtedly additional administrative costs associated to providing itemized billing and time of service estimations for patients. So it's very important to find a system that works efficiently and appropriately for you in order to provide these services. Obviously, when you are restricted from sending patients to collections, you're going to lose some revenue there. And then, of course, the state could also mandate a significantly lower reimbursement rate in these out-of-network scenarios. All of these have the potential to negatively impact your revenue cycle. Therefore, I really do encourage everyone to review the current laws in your individual states. You want to be sure that your contracts and your processes for handling patient population are sufficient to keep you profitable. And now we'll look at the CMS 2018 proposal. So we'll switch gears just slightly. While I know that this is a federal program, I wanted to first review changes in legislation at the federal and state level and really pull this ruling out separately, as it has some significant updates directly impacting the ASC market. The CMS 2018 Hospital Outpatient Prospective Payment System and Ambulatory Surgery Center Payment System proposed ruling is such a mouthful that I am going to refer to it as the OPPS proposal moving forward in this presentation. The 2018 OPPS proposed ruling is Medicare's latest edition of potential changes in our market space. Final comments were due to CMS by September 11th, and we expect the final ruling to be released by the end of October or early November. Now, I want to highlight something at this point because in my more recent dealings with Medicare, I've identified that as a governmental body, they really do want and need feedback from stakeholders in the industry. Too often, it might only be the larger groups or national organizations that formally produce and submit comment letters on CMS proposals, but there's absolute opportunity for each provider, administrator, or individual facility to submit their own unique comments. Comment letters do not have to be expansive or very formal, and I encourage all of us to become more involved in this process. This really is an opportunity to have a voice in the decision-making process that influences federal regulation, which subsequently influences how we can operate on a daily basis. Additionally, I have seen CMS make revisions to their proposals based on the feedback that they've received, so you most certainly have influence through this process. So I want to highlight several of the key concepts in this proposal and dive into how this impacts us in the ASC industry. Generally speaking, CMS proposed a 1.9% increase in ASC payment rate for facilities who meet quality requirements. There are proposals to move total joint procedures to the ASC covered procedure list, an investment of an additional $155 million in total payments to ASCs in 2018 compared to the previous year, and a proposed delay of the OAS CAP surveys and some changes to quality measures. So we'll take a look at each more closely. Here you see the impact of proposed rate change on the top 100 ASC procedures by volume. Dermatology is expected to have just over a 6% increase in rate compared to others where we may see little to no change in rate. So I want to focus in on a few of the device-intensive procedures that are migrating to the ASC space and identify where the impact hits the revenue cycle. Now, I will discuss the general 1.9% ASC payment rate increase from this proposal toward the end of the presentation, as it ties directly to some additional legislation that I want you to be aware of. So for now, we'll just focus on a few specialties, beginning with orthopedics. The 2018 OPPS proposal includes a 4.5% increase in payment rate for orthopedic procedures, which is actually among the higher increases in payment rate for a single specialty. Total joints in the ASC setting are not necessarily new. There are many ASCs who have been performing total joints for a very long time, and they've been doing so safely and profitably. In fact, we have several clients who are doing that today. The OPPS proposal is looking to add total knee arthroscopy and partial and total hip arthroscopy to the ASC covered procedure list. And while we're excited to see this migration of total joints to the ASC approved list, there are some in our industry that are anxious to really better understand what the reimbursement for these procedures will look like through CMS. I think a valid concern is that reimbursement rates will not properly reflect the cost that's associated to providing this care in the ASC setting, even though there is a significant cost savings compared to these procedures being done in hospitals or hospital outpatient departments. And as a result, the worry is that it may lead to this inverse migration of procedures going back to the hospital setting because the ASCs would not be able to afford performing them. So obviously, this would be counterproductive to the general push for moving procedures to the ASC lower cost and high quality setting. So we'll continue to monitor these reimbursement rates. And obviously, these procedures involve implants and therefore will require that your contracts appropriately reflect the implants that you use and their associated costs. The quality of coding in this case is also going to be essential to ensuring that you're being paid appropriately. Spine is another device-intensive specialty that's quickly growing in the ASC market. Looking back at just 2016, we had 13 spine codes that were added to the ASC approved list, and those codes were associated to over 5,000 cases from the previous year. As an industry, we saw a 34% increase in spine procedures being performed in the ASC setting from just 2015 to 2016, and that trend continues today. The 2018 OPPS proposal did include the addition of a few HCPCS codes to the ASC payable list related to cervical artificial discectomy and second-level cervical discectomy. Now, similar to your orthopedic reimbursement concern in spine, the cost of implants and their subsequent reimbursement rates may dictate whether or not it's cost-effective to perform these procedures in the ASC setting. An example that you can see here is the proposed reimbursement rate for code 22856, the cervical artificial discectomy. It's just over $11,000. Now, with the cost of premium implants being anywhere from $8,000 to $15,000, it's easy to see how this could end up not being profitable for a facility. Now, you do have options when you're shopping for implants. You have the ability to negotiate good global rates, and you can also explore commodity implants, which are typically less than about 50% of the average market cost for premium implants. As a previous administrator for a spine surgery center, I very much understand that trying to move a surgeon away from his preferred implant can be very difficult. But I do believe that it's very helpful in these scenarios to include the surgeons in these discussions when you're looking at costs and profitability. And again, you must also be mindful of your contract carve-outs with regards to implants for spine procedures. Cardiac procedures are the newer player in town in the ASC market. It's really no surprise that as technology and medicine advance, we begin to see more and more procedures that were originally believed to be too difficult to be performed anywhere but a hospital, now migrating to the outpatient setting. Cardiology is a specialty that's quickly transitioning, moving procedures like pacemaker placement and catheterization with stenting to the ASC setting. Now, because this is still so new and it's rapidly moving, at this point, collective data on quality and cost is not readily available. But what we do know is that coding is going to be the focus here. You really need to have specialized coding done by cardiac coding experts because of the rapid movement with this specialty. Similar to other device-intensive procedures discussed, implants and their associated costs and reimbursements are the most difficult part to navigate with this specialty, but we do expect to see consistent growth in the ASC market in terms of cardiology procedures. CMS is also proposing some changes to quality measures and subsequent reporting in their 2018 proposal, and it is important that you're aware of these proposed changes to ensure that you're compliant with reporting so that you can prevent rate penalties moving forward. CMS is proposing the removal of ASC 5, prophylactic IV antibiotic timing, ASC 6, safe surgical checklist use, and ASC 7, which is ASC facility volume data on select ASC surgical procedures. And they're proposing removing this from calendar year 2019 payment determination. The proposal also includes the introduction of new measures, ASC 16, ASC 17, and ASC 18. That's toxic anterior segment syndrome, hospital visits after orthopedic surgeries, and hospital visits after urology procedures. And with the headlining proposal for total joints moving to the ASC setting, obviously CMS will want to track quality there. So what do these changes look like from a reporting perspective? Well, there's really no change to ASC quality measures 1 through 4. These are still going to be done on claim submission forms where data is taken directly from the CMS 1500 form, and the same will apply for quality measures 17 and 18. ASC 8 is the influenza vaccination coverage check. Now, the CDC has released a requirement for an updated agreement and consent that will be released to users in December of 2017, and it is imperative that you complete these updates to be able to continue assessing the system for reporting purposes. ASC quality measures 9, 11, 13, and 14 will all be reported via QualityNet, so no major changes there. And ASC quality measure 15, the OAS CAP survey, will be done through 2018. Now, the 2018 proposal does include the potential delay of this quality measure through calendar year 2018, which I know is an effort strongly supported throughout our industry. These surveys have 37 questions that cover numerous topics, and the struggle thus far has been related to the actual administration of these surveys. A facility is required to use a CMS preferred vendor for survey distribution, and the facility needs to have 300 completed surveys, which in today's world you can imagine is difficult to get when there's no electronic version available. So we'll have to continue to watch the changes there. And we're collecting this data really because there aren't any true quality rating systems within our industry. I actually commend CMS for at least having the data associated to these measures. It's a step in the right direction, but of course we do have a long way to go. Now, the link you see here will take you directly to the reports page for CMS, and it's called Hospital Compare, where individual facilities, states, and national data is compared. Now, this information is publicly available to consumers, providers, and insurance carriers. Therefore, it's appropriate to think that good or bad ratings here may have an impact on your patient volume and subsequent revenue. Additionally, as we've seen, CMS uses this data to also help guide quality areas of focus from a research perspective, and also to guide appropriateness of care in the ASC environment. And now I recognize that reporting on quality measures is seen as an administrative burden for some, so please note that there are organizations who offer services to support the administrator with information submission. Let's finish today by looking at a piece of ASC legislation and advocacy. So earlier I skimmed over the 2018 proposal to increase ASC payment rates for those facilities who meet quality requirements by 1.9%. And the reason that I did so is because there's more to talk about regarding how this actually translates across the healthcare spectrum. First, it's important to note that the ASC budget through CMS is site neutral, which would indicate that if the rate of reimbursement increases for any particular specialty, then we would see a reduction somewhere else. So for owners or administrators of multi-specialty ASCs, you want to be sure to properly understand the reimbursement of your case mix. Additionally, although there is a proposed 1.9% increase in ASC payment rates, administrators also need to consider facility expenses, staffing salaries when determining profitability. As a business leader, you have to account for all areas of inflation. And that brings me to the current legislation making its way through the Congress that addresses the inflation rates and some other critical areas of the ASC industry. The Ambulatory Surgery Center Quality and Access Act, Senate Bill 1001, is legislation focused on appropriately categorizing the ASC market and targets some key needs in our space. In short, this legislation looks to move the ASC inflationary index from the CPIU index to the hospital market basket or similar, which I'll talk about on the next slide. This legislation would require CMS to post comparisons between ASCs and hospital outpatient departments for purposes of public reporting, which we believe would highlight quality of care occurring more in the ASC space due to specialization and other factors. The legislation also proposes the addition of an ASC representative to the advisory panel for the Hospital Outpatient Policy and Payment Group. This seems to be an extremely fair ask, considering that this CMS division is responsible for making decisions that impact ambulatory surgery centers. However, to date, there is no specific ASC representation on the panel. Lastly, this legislation calls for some transparency. As it currently stands, we have access to what the ASC exclusion list for CMS looks like. However, when a procedure is denied from that list, CMS does not currently provide the actual criteria used for exclusion. So it's believed that by having this data, it will allow ASCs to more properly adapt practices to promote procedures moving to the ASC setting. So why is the CPIU, or the Consumer Pricing Index for all urban consumers, significant to discuss for ambulatory surgery centers? Well, this index measures rate of inflation and subsequent payment based on all consumer goods, things like travel, cost of groceries, cost of energy, and that's the scale that ASC payment rates are based on. Hospital outpatient departments and hospitals are on the hospital market basket, which is an index that determines payment rates and scales based on cost of providing medical care. So things like nursing salaries, cost of disposable supplies, and prescription drug pricing. It's believed that the CPIU index does not properly reflect the costs associated to providing medical care and is therefore not an appropriate determinant for the ASC space. You can clearly see with the graph on this screen that there's a significant difference between the two indices, with an approximate 50% difference in the CPIU and hospital market basket in favor of hospitals and HOPDs. So understanding that ASCs do not necessarily function like hospitals or hospital outpatient departments, the hospital market basket might not be immediately transferable to the ASC space. However, part of the proposal is the potential development of an ASC-specific basket to properly reflect cost of care in that setting. Now, the greater concern with this is not so much reimbursement rates, but the effect that this great discrepancy will have on procedures performed. As we discussed when looking at device-intensive procedures, and something that we're already seeing with some specialties like plastics, orthopedics, even urology and podiatry, it's that although these procedures are safe and more appropriate to be performed in surgery centers, where it will cut costs and improve quality, the reimbursement is such that ASCs cannot afford to perform the surgeries, and therefore we're seeing that inverse migration of some procedures back to the hospital setting. And thus the cycle continues where we're performing surgeries in a high cost setting when there's a lower cost option. The example here shows a significant decrease in knee arthroscopy in the ASC setting between 2010 and 2014 due to costs, not ability to perform. So if this trend and discrepancy in market basket continues, there is concern that the inverse trend will continue as well. So what can we do? Well, most important is to educate yourself on the legislation impacting your state, your specialty or your specialties, and federal regulation. We're a growing market with a great deal of attention at this time when everyone is focused on cost containment and quality, and there's no better advocate for the ASC market than each of us. I've recently had a wonderful opportunity to visit Capitol Hill and meet with lawmakers to promote their understanding of ambulatory surgery centers and the significant impact that we have on the healthcare system. We're a quickly growing area in healthcare that will require that we get involved. As you can see here, according to the Congressional Management Foundation, 74% of House members and senators indicated that a visit from a lobbyist was influential in their decision-making as it pertained to supporting legislation. And there was an additional 8% that indicated this method was very influential in their decision-making. There are, of course, other ways to get involved listed here, and there are some not even on the screen, but I do encourage you to invite your local legislators to visit your facilities. You want to help them learn more about surgery centers and what we can do in that space. And so in closing, I'll just leave you with this. This market is quickly changing. Healthcare reform remains in flux. And of all of these changes, there really is potential to have a great impact on our ability to operate and stay profitable in the ASC environment. It's crucial that you remain knowledgeable about your state laws and federal regulations, and that you're educated about how to properly manage your revenue cycle accordingly. Growing demands for price transparency, accurate coding and billing, and contract management are really key areas of focus to support a healthy revenue cycle. Thank you so much.
Awesome. Thank you, Kylie, for that presentation. We'll now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space-labeled answer question for staff and clicking send. We will try to get through as many questions as we have time for. Scott, I'll now turn the floor over to you to get started.
Kylie, thank you very much. It's a terrific presentation and reflects well on national medical billing to have such great resources internally. What a great team you guys have built. So here's a number of questions. Let me start with, have you seen surgery centers successfully contract with large employer groups? One of the questions from our audience. Any sense of that, Kylie?
It's absolutely happening. There are some major players in the game contracting with large organizations like Lowe's, for instance. And I think really the key there is to make sure that your other contracts with major payer groups do not limit your ability to do that. So as I mentioned earlier, in managed care contracts today, we're seeing this increased trend where they're putting essentially a non-compete into contracts where they're not allowing you to do the direct contracting with employer groups. So as long as your contracts do not state that, you have the ability to go out and contract with employer groups.
Thank you very much. And you're seeing some of it, not a huge amount, but some of it. And it sounds like you got to be aware of the conflict, potential conflict with your own payer contracts. So that's an interesting evolution I wasn't familiar with. Thank you very much. Next question. Correlation between reimbursement rates between Medicare and commercial payers. What are you seeing here in terms of the correlation between rates? Is it are payers getting closer and closer to making rates congruent with Medicare rates, or what are you seeing out there?
Yeah, so there really has been this ripple effect from Medicare and their reimbursement rates really setting the standard, if you will, trickling down into areas like self-funded plans, certainly in the workman's compensation arena, and now even with several of the commercial payers where their rates are based on a percentage of Medicare. And we're also seeing a correlation in methodology between Medicare and commercial payers where the payer guidelines are mimicking that of Medicare with regard to medical necessity and experimental procedure language. And so this ties into the earlier discussion about reimbursement concerns for device-intensive procedures in the ASC setting. So as we're looking to properly understand what Medicare reimbursements will look like for, orthopedic or spine cases, we also have to watch what reimbursements are looking like from commercial payers and self-funded plans. What we don't want to see is that inverse migration of procedures back to a hospital setting as a result of inadequate reimbursement.
Got it. So let me ask you another question. The opportunity for revenue cycle with respect to the migration of device-intensive procedures to ASCs. With the device-intensive procedures, total joints, knee replacements, et cetera, where do you see the greatest opportunity from a revenue cycle perspective?
So there really are several areas of focus to improve revenue cycle, particularly with device-intensive procedures. Some of them I mentioned earlier, and others I'll touch on here quickly. First and foremost is training of your front-end staff. You want to make sure that your team is properly capturing patient demographic and insurance information, and you want to make sure that they understand how to run eligibility reports. As I mentioned earlier, knowing your patient population and what your employer groups are will be absolutely essential to properly managing that patient population. And also understanding your contracts, knowing what your carve-outs are, particularly with implants related to device-intensive procedures, what those costs are, properly managing around that. That's really the key opportunities with revenue cycle and device-intensive procedures.
Thank you. The HCAHPS survey delay proposal, what does that mean for ASCs? Does that mean they won't be required to collect data in 2018? Will they have to collect data? Will they be penalized? Could you just give us a little bit more insight on that?
Yeah, that's actually a great question. It's certainly a hot topic. I know the ASC industry has really been looking forward to having ASC-specific patient satisfaction surveys, and we have that now with the OAS caps. So CMS is proposing to delay implementation of these surveys beginning with calendar year 2018 data collection, and they're delaying this until action is taken in future rulings. Organizations that want to continue administration of the survey under voluntary national implementation will be allowed to do so in 2018. CMS did release their rationale for this delay. They wanted to ensure that the survey measures appropriately account for patient response rates, really both aggregate and by survey administration method. They also wanted to reaffirm the reliability of national OAS CAP survey data, and they wanted to appropriately account for the burden associated with administering the survey in the outpatient setting. So originally 2018 was the first year that data submission would be linked to reimbursement. However, now 2018 is being considered a voluntary year, which means that it will not be linked to reimbursement. ASCs will not be penalized on 2018 reporting, but it is encouraged that facilities take part in the voluntary period to become familiar with the system. However, we do recognize that there are costs associated to survey administration, so perhaps it's not feasible, but there will be no penalty to 2018 data collection.
There's a question on SSI infections, and is the concept of CMS with these penalties that essentially the penalty will turn into unreimbursed care for the ASC? How exactly do people start to feel the penalties for the SSIs and infection complications?
I think we're going to have to wait until the final proposal is released over the next week or two to determine CMS's final approach on that. I do recognize, being a registered nurse and previous administrator, that surgical site infection is an extremely important topic in the ASC setting. We want to eliminate risk of infection as much as possible. So I do expect that CMS will take a pretty hard stance on that.
Gotcha. In terms of device-intensive procedures, the CMS current view of these in light of the OPPS 2018 proposed rule? What's the CMS view of device-intensive procedures and how they get reimbursed under the 2018 proposed OPPS rules?
Sure. In the 2018 OPPS proposed rule, CMS is really not proposing any changes to its policy for determining whether a procedure is device intensive. They're maintaining their calculation at 40% at the HCPCS code level. They also really haven't provided any additional detail regarding the methodology used for calculating device offset percentage, but they have proposed some changes to some of their policies, to the device offset policy for procedures that are considered device intensive and are subject to the no cost, full credit, and partial credit device adjustment policy. Now, I know many advocacy groups are appealing to CMS in this ruling for the disclosure of the calculations used to better understand what CMS is using to determine device intensive thresholds. And they're also asking for a formal review of the device-intensive policy to ensure that it's appropriate with this growing volume of orthopedic, spine, and even cardiac procedures moving to the ASC space. So it'll be interesting to see what their final ruling states on the matter, but we are hopeful that they will be considering the comments of advocacy groups.
Kelly, I want to do this. We should probably wrap up right about now. We're at 2 o'clock. We've had a great deal of the questions. I know there were so many more that we won't have time to answer. You've done a magnificent job on this. I measure that by, we had several hundred people that have stayed on all the way throughout your entire presentation and through a few hundred through your question and answer, which is a sign of someone that's engaged the audience. I also appreciate so much the strength of national medical billing and the fact that the webinar completely informative and no selling at all of NMBS, which is one of the top, if not the top revenue cycle companies in the surgery center business. So just a terrific presentation, very educational and just great. I want to thank you so much for joining us today and providing this presentation. Just fantastic. Thank you.
Thank you so much, Scott.
Great. Kylie, is there contact information for you and your team And just if you could quickly provide that, I didn't mean to catch you off guard.
No problem. We encourage everyone to visit our website. You can reach out to individual members of our leadership team there, but also up on the screen is info@nationalascbilling.com. You can send us any of your questions, and we're happy to continue conversation.
That'd be great. Kylie, thank you so much. It's a tremendous, informative webinar. Thank you very, very much. We're going to wrap up, and thank you to all that attended and joined us. Thank you.
Thank you.